anticoagulation for continuous renal replacement therapy, and I will focus on regional citrate anticoagulation. Here you see my conflict of interest. So once we start renal replacement therapy, the first question is, do we have to use anticoagulants? And it's quite easy to answer this question because the answer is yes. Because once we start renal replacement therapy, the blood is exposed to the extracorporeal surface, and this activates the coagulation system, which might subsequently plug the filter. And this has negative consequences, because once the filter gets plugged, we have to discontinue renal replacement therapy. That means the dose goes down, we cannot deliver the prescribed dose, and this might increase the mortality. In addition to this, the blood which is in the system cannot be retransfused. So if this happens more frequently, we have to transfuse red blood cells. And of course, we have to change the filter, the set, and this increases the workload as well as the healthcare costs, because normally we can use the filters up to 72 hours, but if we have to change them prematurely, then the costs will go up. In addition to this, if the filter gets plugged, the pressure in the system goes up, and this triggers the alarm. Here you see that we have different anticoagulation options. There are still some countries in which physicians don't use any anticoagulations for continuous renal replacement therapy. These physicians try to prevent filter clotting by increasing the blood flow. On the left side, you see that we can use systemic anticoagulation. Here we have different options. We can use heparin, low molecular weight heparin, and I will talk about the advantage and disadvantage a little bit later. And we can also use direct thrombin inhibitors, but this is not a widely accepted approach. On the right side, you see that we have different options for regional anticoagulation. We can use the heparin-protamine approach. That means that we infuse heparin immediately before the filter, and then we antagonize the heparin effect immediately after the filter by infusing protamine. The most commonly used method is the regional citrate anticoagulation, but we can also use prostacyclins. If we want to use systemic anticoagulation, then we have to think about the advantage and disadvantage, because they influence our decision-making process. If we want to use systemic anticoagulation, this has some advantage because it's independent of dialysis circuit, and we can use it in patients who need a therapeutic anticoagulation, for example, patient with aortic or mitral metallic valves, or patient with an atrial fibrillation. However, if we want to use this method, this has also some disadvantage because the risk of bleeding increases, and there are issues with reversal and dose of antidote, and the systemic anticoagulation is affected by endogenous coagulation status. And if we are talking about regional anticoagulation, we often talk about regional citrate anticoagulation. And this method has several advantages. It's safe, it's effective. The need for red blood cell transfusion decreases. This has been shown in several trials. And it can be safely used in patients with an ongoing bleeding, especially in surgical patients. If we want to use this method has also some challenges because it has to be used correctly, and you have to have at least some experience with this method because you have to monitor the ionized calcium concentration on a regular basis. And how does regional citrate anticoagulation work? Here on the left side you see the coagulation system, and I don't want to go into detail, you all know this. I only want to highlight that calcium is required for each step in this coagulation system. And if you add citrate to the blood, you bind calcium so that the calcium is not available for the coagulation system, so you block the whole system. And here on the right side, you see how this method works. Blood is withdrawn from the patient, citrate is added to the blood, and the target value of the ionized calcium concentration is 0.25 to 0.4 millimole per liter. And after the filter, calcium is added to the blood so that the ionized calcium levels are normalized. But we have to keep in mind that 40 to 50% of the citrate calcium complexes are removed by the filter. When we use heparin as an anticoagulant, then there is a linear relationship between the dose of heparin and the anticoagulatory effect. This has been nicely shown in this study. So if you give more heparin, the ACT goes up. But we don't have this linear relationship when we are using regional citrate anticoagulation. On the left side, you see that there is a linear relationship between the citrate concentration and the ionized calcium concentration, but there is no linear relationship between the ionized calcium concentration and the anticoagulatory effect, as you can see here on the right side. Normally, we have an ionized calcium concentration of 1.1 to 1.25 millimole per liter in the blood, and we have to bring it down below 0.4 millimole per liter to see an anticoagulatory effect. And to achieve an ionized calcium concentration below 0.35 millimole per liter, we have to add 4 millimole citrate per liter blood. If we want to use this method, we have to understand how citrate gets metabolized to understand when we cannot use this method. So citrate chelates ionized calcium, resulting in complex formation. The citrate gets metabolized in the liver, skeletal muscle, and kidney to bicarbonate. So one molecule of trisodium citrate gets metabolized to 3 molecules of bicarbonate. And the beauty of this system is that citrate only acts regional. It doesn't affect the systemic coagulation system. So the question is, what can go wrong when using citrate, and in which patient can we not use this method? Actually, regional citrate anticoagulation doesn't have a formal contraindication, but there are diseases and syndromes in which the risk of citrate accumulation is elevated, and this is shock, mitochondriopathies, and liver failure. So what are the first signs of citrate accumulation? And the first sign is that the patient develops a metabolic acidosis. As I told you, 1 mole citrate gets metabolized to 3 mole bicarbonate. And if we use regional citrate anticoagulation, we have to use a specific solution. This solution doesn't contain any calcium, and it has a lower bicarbonate concentration compared to standard solutions. So the 1 mole citrate gets metabolized to 3 mole bicarbonate, and this bicarbonate compensates for the low bicarbonate concentration in the citrate solution. And if citrate doesn't get metabolized to bicarbonate, the patients develop a metabolic acidosis. And the second sign of citrate accumulation is a hypocalcemia, because calcium is not released from the citrate calcium complex because citrate doesn't get metabolized. So the need for calcium substitution increases. And here you see the complications and consequences of citrate accumulation. So the metabolism goes down, the patients develop a metabolic acidosis and a severe hypocalcemia, and this might lead to a reduced myocardial contractility and vasoplegia. The question is, can we use regional citrate anticoagulation in patients with a liver failure? And this multicenter open prospective observational study answered this question, and the answer is yes, we can use regional citrate anticoagulation in these patients. So they recruited 120 patients, 40 patients with a normal liver failure, 40 patients with a mild liver failure, and 40 patients with a severe liver failure. 7 centers in Europe participated. And they looked for the arterial pH and for the arterial bicarbonate before and after initiation renal replacement therapy with regional citrate anticoagulation in all the 3 groups. And they demonstrated that the pH and the bicarbonate concentration didn't change over time in the groups. And they also looked for citrate accumulation, especially in patients with a severe liver failure, and they looked for the calcium, ionized calcium ratio. If this increases above 2.5, this is a sign of citrate accumulation. And here in the lower table, you see that the ratio didn't increase above 2.0 in patients with a severe liver failure. That means that liver failure alone is not a contraindication for this method. In this retrospective analysis, which looked at more than 1,000 patients, the authors investigated the incidence of citrate accumulation, and they identified that 32 patients developed a citrate accumulation. That means it is an incidence of 2.9, and the incidence of 2.9 is as high as the incidence of heparin-induced thrombocytopenia in patients who are treated with heparin. However, we have to admit that the mortality rate in the patient who developed a citrate accumulation was quite high. 31 of 32 patients died. So the question is, why should we use regional citrate anticoagulation? And this is a landmark study published already 14 years ago. This is a single-center study. The authors randomized 215 patients. 200 patients received CVVH according to a predetermined protocol. 97 patients received regional citrate anticoagulation, and 103 patients received heparin. And the authors demonstrated that the complication rate in the regional citrate anticoagulation group was significantly lower. Only 2 patients developed a complication, a citrate accumulation and filter clotting, compared to 16 patients in the heparin group. Here, 16 patients had a complication, especially bleeding and thrombocytopenia. Surprisingly, the filter lifetime was comparable between both groups. But they also looked for the mortality, and they divided surgical patients from non-surgical patients. And in surgical patients, they demonstrated that patients who received regional citrate anticoagulation, that these patients had a significantly lower mortality rate, as you can see here on the left side. But this difference was not detectable in medical patients, as you can see here on the right side. This Cochrane analysis was published 3 years ago, and the authors looked for the major outcomes, and they demonstrated that death and successful prevention of filter clotting was similar between regional citrate anticoagulation and anticoagulation with heparin. But they also demonstrated that major bleeding was significantly lower in the group who received regional citrate anticoagulation. And I also want to go back to the KDIGO guidelines, and we find a couple of recommendations regarding anticoagulation. The first recommendation is we recommend using anticoagulation during renal replacement therapy in AKI if a patient doesn't have an increased bleeding risk or impaired coagulation and is not already receiving systemic anticoagulation. The evidence was quite good back in 2012. It was a 1B recommendation. And the second recommendation was for anticoagulation in CRRT, we suggest using regional citrate anticoagulation rather than heparin in patients who don't have contraindication for citrate. This was only a 2B recommendation, so there was obviously not enough evidence. Based on this recommendation, we performed a large multi-center trial investigating the effect of regional citrate anticoagulation versus systemic heparin on dialysis filter lifespan and mortality among critically ill patients with acute kidney injury. And here on the left side, you see that we screened 5,000 patients, and we included 638 patients. 319 patients were randomized to receive regional citrate anticoagulation, and the other group received systemic anticoagulation. On the right side, you see the demographics, and this was quite balanced. We had 2 secondary co-primary outcomes. The first one was the circuit survival, and the second co-primary outcome was a 90-day mortality. On the left side, you see that if you use regional citrate anticoagulation, you can increase the survival, the filter survival. But if you look at the right side, there was no signal regarding mortality between both groups. And we also looked for secondary outcomes. One major secondary outcome is, of course, bleeding, and the bleeding rate was significantly higher in patients who received systemic anticoagulation. But surprisingly, we also detected a higher infection rate in patients who received regional citrate anticoagulation, and this was defined as new culture-proven infection since start of dialysis, and this was also significantly elevated in the regional citrate anticoagulation group. And we wanted to investigate this a little bit further. We performed a postdoc analysis, and we demonstrated that a longer filter lifespan was associated with an increased infection rate, and the type of anticoagulation didn't have a direct effect on the infection rate, but of course, if you use regional citrate anticoagulation, you prolong filter lifetime, and this will lead to an increased infection rate. So in conclusion, we can say regional citrate anticoagulation significantly prolongs filter lifetime. Regional citrate anticoagulation has no effect on mortality of critically ill patients with a severe AKI compared to systemic anticoagulation with heparin. Regional citrate anticoagulation reduces bleeding complication, and in patients receiving regional citrate anticoagulation, the number of metabolic complications and the infection rate increase compared to systemic anticoagulation with heparin. Thank you very much for your attention.
Thank you very much, Alex, for a very comprehensive talk. I'm sure in the audience there are some people that are still not using citrate and are contemplating introducing citrate. What would be your advice on how to introduce citrate in a center? You've convinced us that's the way to go, but...
So first of all, I would use a published protocol to establish regional citrate anticoagulation in your own ICU if you're not familiar with this, and then first of all start with patients who don't have a lot of comorbidities. I wouldn't start regional citrate anticoagulation in high-risk patients, for example, patient with a liver failure. I would start in easy cases, let's put it this way, and then try to implement this. And first of all, I would recommend to measure the ionized calcium concentration on a regular basis until it works, until the protocol that you want to implement works for you, and then you can reduce the rate of measurements.
There was a question about the use of pre-dilution, whether it can help to survive, to prolong your filter life. Pre-dilution in a...
Yes, of course, pre-dilution in general, doesn't matter whether we use regional citrate anticoagulation or systemic anticoagulation, improves filter lifetime, but the efficacy, of course, if we use pre-dilution, goes down. So there are some ups and some downs of this method.
And then one more question about the use of citrate in metformin intoxication. Do you know anything about that one?
So that's a good question. We've never tried this, but I would like to answer this question a little bit different. So you can also use regional citrate anticoagulation in patients after liver transplantation. So initially they don't have a liver function, but you can safely use regional citrate anticoagulation. But I wouldn't use regional citrate anticoagulation in patients who have lactate levels above 10. That's at least our cutoff value for using regional citrate anticoagulation, because then you know that the citrate cannot be metabolized, and that's a cutoff. And if the patient with a metformin metabolic acidosis have a lactate level above this threshold, I wouldn't use it. Below this threshold, I would try it, and if the lactate levels go further up, then I would stop it and change and switch to systemic heparin anticoagulation.
Okay, so thank you. We would like to go to the next speaker, who is my co-chair,